So I did my project on Alzheimer's disease, and I'm going to start by differentiating between dementia and Alzheimer's because I feel like they're often confused. Dementia is a syndrome, while Alzheimer's is a disease, and dementia describes a variety of symptoms that can impact your memory, performance in basic tasks, and communication, while Alzheimer's disease is the most common type of dementia, and it's described as progressive decline in cognitive function, usually leading to total dependence. As far as epidemiology goes, there are 24.2 million people worldwide that have dementia, and this number is expected to double every 20 years until at least 2040. And 4.6 million new cases every year of dementia are reported, with 70% being attributed to Alzheimer's disease. There are 5 million people in the United States alone that have Alzheimer's disease, and this is expected to triple by 2050. So in this graph, you can just see this is the worldwide prevalence in individuals 60 years of age and older, and North America has the highest prevalence rates. 95% of patients that have Alzheimer's are 65 years of age and older, and this is referred to as late-set Alzheimer's disease. There's also early-set Alzheimer's disease, but that's only 1 to 5% of cases, and it usually occurs in the 4th or 5th decade of life. So as far as prevalence rates go, it increases exponentially as a person ages. So women typically have a higher risk than men just because they live longer. And risk factors include cerebrovascular disease, high blood pressure, type 2 diabetes, and other metabolic syndromes. And actually, type 2 diabetes nearly doubles somebody's risk for Alzheimer's disease. Being underweight, being overweight, having a history of depression, chronic psychological stress, and traumatic brain injury. There are some protective factors. Physical activity, a healthy diet, specifically a Mediterranean diet because it's high in omega-3 fatty acids, and intellectual activity like mazes, puzzles, sudokus, word searches, anything of that sort. So as far as brain structure goes, the cause of Alzheimer's is unknown, but it's most likely a combination of genetic and environmental factors. With Alzheimer's, though, you will see atrophy of the brain, initially in the hippocampal region, which is responsible for the memory formation. So as you can see in this image, there's a healthy brain and then a brain of somebody who has advanced Alzheimer's. And first looking at the hippocampus is essentially gone on the right side, and the rest of the brain has deteriorated quite a bit too. With plaques, tangles, and neurons, there is one theory regarding the neurodegenerative process that occurs in the brains of these patients, and it has to do with an accumulation of abnormally folded amyloid beta and tau proteins in plaques and tangles in the brain. This is very signature of Alzheimer's disease, and it causes neurons to die because they stop functioning and lose their connections with other neurons. And although 30 years of studies have supported this, the research keeps progressing, and as it does, they're finding that this is such a complex disease that there can't be one linear cause for it. So in these two images, you can just see an animation and a real picture of a normal neuron versus a neuron in somebody who has Alzheimer's disease, and you can definitely see how the tangles and the plaques are affecting that neuron's functioning. The disease, as most diseases do, varies in how it progresses. There is the preclinical phase, which can last a decade or more. And the thing about this phase is that there is no clinical diagnosis because the patient seems symptom-free. However, toxic changes are occurring in their brain, and this can be seen through various brain studies on abnormal biomarker patterns. In stage 2, there is mild cognitive impairment due to what is thought to be Alzheimer's disease, and the third stage is full-blown Alzheimer's dementia. Once you're diagnosed, a patient can typically live 4 to 8 years, but the upper limit of that is living about 20 years after your diagnosis. So aside from having 3 phases, it also has 3 stages: mild, moderate, and severe. And we're going to go through and talk about the symptoms in each of these stages and how they're different. So in the mild or early stage, the patient is still functioning independently. They can drive, they can work, they can do all their social activities, and the patient and close relatives, however, and even their close friends, can notice lapses in the memory and difficulty with finding the right words or names, remembering new names, remembering what they just read, performing tasks in social or work settings, planning and organizing, and losing or misplacing items pretty frequently. In the second or moderate middle stage, typically the longest stage of the disease, there is a greater level of care that's required. There's damage to the neurons that make it a challenge to express thoughts and perform routine tasks, and the symptoms at this point are noticeable to everybody that comes into contact with the patient. They're confusing their words, they're having mood swings and acting unexpectedly, forgetting parts of their own life, they have confusion regarding where they are, what the day is. There's assistance that they need to choose appropriate clothing for the season or the weather that day. They're incontinent typically, or becoming incontinent, and they have a change in their sleep pattern, so they'll sleep all day and then be up all night. They're also at a high risk of wandering or becoming lost, and a lot of them have delusions and compulsions and are very suspicious of what's going on around them. Now, symptoms in the severe stage or the late stage, there's no response to the environment from the patient. They can't carry a conversation, they can't control movement, there's significant personality changes, they become completely dependent on somebody else or multiple other people, and they have no awareness of recent experiences or surroundings. Challenges, and eventually they have challenges and eventually lose their ability to walk, sit, and swallow, and they have a high vulnerability to infection, so really difficult disease to be dealing with. For diagnosis, Alzheimer's can only definitely be diagnosed post-death. However, doctors can use these concepts to make a pretty solid guess whether or not a patient has Alzheimer's. So they could ask the patient and family questions regarding the patient, including their medical history, their overall health, their ability to carry out activities of daily living, and any changes in behavior or personality that have been occurring recently. So they give assessments on memory, problem-solving, attention, counting, and language to the patient as well, if they so choose, and they perform other medical testing and brain scans to rule out any other possibilities, such as a UTI, which also causes confusion. For management and medications, there is no cure for Alzheimer's disease. However, exercise is medicine, and aerobic exercise early on in the disease leads to an increased functional ability, specifically with cardiorespiratory fitness, which improves memory performance and reduces atrophy of the hippocampal region, therefore delaying the progression of the disease in a lot of cases and also easing certain symptoms. And there are current FDA-approved medications for the treatment, but it's only for symptoms. It does not modify the pathology of the disease in any way. Medications are mainly used for the purpose of comfort, dignity, extended independence, and for assisting caregivers. And here you can just see a chart of the medications, and what you want to focus on is the far right column, which talks about possible side effects that would interfere with the exercise response. The two that stood out to me the most, some medication precautions, were with Exelon. There's muscle weakness as a side effect, so I'd recommend low impact, possibly even gravity eliminating exercise, like in a pool, if that's available to you. And with Namenda, there's a fall risk because it produces dizziness and also increase the risk of confusion in the patient. So stick to exercises that do not require much balance, maybe a recumbent bike or a recumbent hand bike, and keep tasks simple to minimize the confusion or stress associated with the confusion for the patient. For the case study, the patient presents as a 75-year-old female with moderate Alzheimer's disease. She's sedentary but a non-smoker and no family history of cardiovascular disease. She is 5'3" and weighs 120 pounds. She is currently only taking Namenda and frequently complains of dizziness thought by doctors to be caused by her medication. Her measured blood pressure is 135/82 in the left arm and 132/80 in the right arm. Her total cholesterol is 198 milligrams per deciliter, with LDLs at 140 milligrams per deciliter and HDLs at 45 milligrams per deciliter. Her fasting blood glucose is 90 milligrams per deciliter. So for risk stratification here, she is older than 55 years old, she's sedentary, she is obese, her BMI is about 34, which is class 1 obesity, and she has dyslipidemia because her LDLs are at 140 milligrams per deciliter. That gives her a moderate risk because she is asymptomatic, but she has more than 2 risk factors. Now, before exercise testing or prescription with this patient, because they have Alzheimer's disease, once you receive clearance from the patient's doctor, spend time trying to educate the patient on perceived physical exertion using a 10-point scale. 0 is sitting and 10 is an all-out effort. And make a visual aid that will be accessible throughout any and all activities, because visual aids are very helpful for persons with Alzheimer's disease. You can see an example of the scale in the bottom right-hand corner. And just for reference, moderate intensity would be a 5 or 6 on this scale, and vigorous would be about a 7 or 8. It's very important also for you as the clinician to notice that with moderate exercise comes a noticeable increase in heart rate and breathing, while a vigorous is a substantial increase. And you need to be paying attention to this to monitor the patient constantly, because they may forget or become confused when you ask them to rate their exertion on this 10-point scale, regardless of your efforts to educate. Also, always consider the risk associated with the disease itself and the medication that the patient is on. In this instance, Namenda, so the dizziness and confusion are the big ones. And I would recommend using the ACSM fit recommendations for older adults and then modify for this patient. For exercise testing, try to choose similar activities for testing as you will for the exercise program, and focus on low-scale activities since the patient was previously sedentary. For aerobic, I chose the Ashran Rhyming Submax Cycle Ergometer test, 6 minutes in duration only, and it's really repetitive. It requires low skill. With muscular strength or endurance, I chose the hand grip dynamometer test and the 5x6 stand test. With flexibility, I would do 1 lower, 1 upper body flexibility test, preferably those that can be done from a chair, so modified sit and reach or a back scratch test. For exercise prescription, aerobic exercise should be the main focus for patients with Alzheimer's disease because it has been shown to slow the progression or ease certain symptoms like their moodiness and abnormal sleep cycle, as it does for anybody else. With frequency, begin with 5 days per week with the eventual progression to 7 days per week. The intensity should be about moderate, so 5 to 6 on that 10-point scale we were talking about, and begin with 30 minutes per day in bouts of 10 minutes each, and eventually go up to 30 to 60 minutes continuously to accumulate about 150 to 300 minutes a week. I would choose aquatic exercise in the shallow pool, a recumbent bike, recumbent hand bike as the primary modes for this aerobic exercise training because it's repetitive, low-impact activities that minimize the confusion and the frustration for the patient while remaining easy on the joints. And these are also safe options to take precautions for medication side effects like the dizziness with Namenda. For muscular strengthening and endurance exercise, frequency should be about 2 days per week with eventual progression to 3 to 5 days a week. Moderate intensity exercise, 5 to 6 on that 10-point scale again, and 8 to 10 exercise involving all major muscle groups, beginning with 1 set of 10 to 15 reps, going on to 2 sets later on. Now the type, I would utilize functional exercises, again to minimize the confusion, so the patient does not need to learn new activities necessarily, as new learning can be really difficult at this stage. So like a sitting and standing from a chair, like a squat type activity, lifting a laundry basket, folding clothes. Also try to incorporate incontinence exercises with pelvic floor training because the patient becomes at risk for incontinence with moderate Alzheimer's. For flexibility, begin with 2 days a week and go up to about 5 days per week. And then stretch to the point of feeling tightness or slight discomfort and hold each stretch for 30 to 60 seconds. Static stretching should be the main focus, and preferably just make sure you hit every muscle group and do slow movements, seated stretches to eliminate this fall risk, like a seated hamstring stretch as shown in the picture, and avoid exercises that require the head to go below the waist to prevent further dizziness and fall risk. And that is what I would do for that case study after all my research, and here are all my sources. Thanks.